Welcome to In Conversation, where we take deep dives into critical access issues for people living in low and middle income countries. My name is Claudia Martínez, and I'm the Director of Research at the Foundation, where I lead our strategic research programs, including our work on access to diabetes care. Through this program, we aim to guide and incentivize companies to expand access to products for people who need them most. And this is critically needed. Diabetes is on the rise. Today, around 9 million people live with type 1 diabetes, which is a critical long-term condition. And we know that within the next 15 years, this number is set to rise to 14 million. And the people who stand to lose the most are those precisely who today do not have access to the tools and the treatment that they need. Children and young people are particularly at risk. In many low and middle income countries, children are often diagnosed quite late or even misdiagnosed. But even if you have a diagnosis, in many cases, families and children will not have access to the insulin that they need, which is critical for their survival, but also the blood glucose monitoring tools, the support, the education, and also the high quality care that they need to live healthy lives. We're going to be diving deeper into some of these topics, and I'm really excited to welcome today Molly Lepeska to our discussion. Hello, Molly.
Hi, Claudia. Nice to be here today.
Fantastic. I want to start before we even go into some of the sort of deeper details of this discussion. Molly, you are a global health communications, advocacy, and campaigning expert. You've been working at Health Action International since 2015. But you're also a technical officer for the ACCISS Study, and I know that we're going to go into more details about the work that you have done as part of this stream of work. And also beyond your professional expertise, you're also a person living with diabetes. So I wanted to start by asking you first, can you tell us a bit more about your role at Health Action International and what led you to focus on improving access to insulin and diabetes care for these communities?
Sure. So just a little background on Health Action International. We are an organization that was founded in 1981 and really with a focus on access to medicines in general and improving access to medicines globally. And I have a background in communications and advocacy. I worked for a long time in HIV before moving over to diabetes. And as a person with diabetes, I started to get involved in the mid-2000s with looking at this issue of access to insulin because the disparities, it was an organization I worked with that was a youth empowerment organization that did work. It was called IUDA, that did work in Dominican Republic and Ecuador and in terms of youth empowerment. And what you really saw in these countries was this huge gap and divide in care between, the U.S. where I grew up and these people, just the access was so different. So we started to look into the issue. And of course, being an American, it's a very expensive condition to treat. We started to look into that issue. But one thing I noticed when I was trying to do the communication and advocacy was there was literally no evidence to really do that advocacy, to really, try and globally push this agenda. And so, in 2015, we started the ACCISS Study. And the ACCISS Study, the aim of the study is to really understand from a global perspective, what are the barriers of access to insulin? And I think we really had to try and take a 360 approach to this, which is really not just looking at maybe issues with the market or trade, but really try and speak to all of the players involved. So understanding what was going on in the industry, understand how, clinicians felt about it, talking to people with type 1 and type 2 diabetes, to really understanding what are the barriers. And then we've sort of expanded since then. We work in 4 countries to really work on country-specific interventions to improve access to insulin and also care.
Yeah, thank you so much for that, because I think the study has been quite helpful in sort of providing the evidence, but also identifying and really shining a spotlight on how the challenges in diabetes care today and access to insulin specifically are so multifaceted, right? And I think this is something that We also see ourselves from the work that we do at the foundation, the level of inequity and, the standards of care that will be quite different for people living in low and middle income countries as opposed to high income countries is something that is just shocking in many cases, right? I wanted to talk to you a bit about some of the work that we've been doing, specifically on the work around children and young people, which we know, and we were talking about this a bit earlier, with type 1 diabetes being a condition that tends to present itself in childhood and requires immediate action. It's not something that you can wait on, right? You need immediate daily insulin and blood glucose monitoring. Some of the work that we have been doing has been on looking at the role of companies and how companies that have leading positions in this market are supporting or trying to close some of the gaps for children and young people. And we recently published a study where we looked at how 4 insulin manufacturing companies, so the leading ones, Lilly, Sanofi, Novo Nordisk, and also an Indian biosimilar medicine manufacturer, are supporting programs that are specific to children and young people. And the research showed that there are around 11 unique initiatives that focus specifically on children and young people. And there are some kind of interesting, good news, positive, outcomes from this research, right? I think on the one hand, we have seen that many of these programs, they are the only ones that sometimes will be available to children, young people, and their families to access support. And they tend to go beyond just provision of insulin, but they take more of a longer term approach, right? But one of the things that we have seen, and I would be very keen to get your thoughts on this, is many of these programs have a certain age limit, understandably so, right, to be able to support more children. But as a young person who's aging out of the program, there tends to be a bit of a cliff edge of support, right? And I wanted to get a bit of your thoughts on sort of what is the challenge that we're facing here, and sort of how do you think that we can address it?
So, first of all, thanks for the report. I know about the initiatives and we've done some work on that, but I was really surprised to see that actually it was only 8% of children in these situations are actually getting care through these initiatives. I was actually surprised how low that is. But I think for me, then you think, okay, of the 9 million people living with type 1, I think 30% are, under the age of 20. So that leaves 70% of people then above that age range. And if, children are getting 8% of care, people above that are getting nothing. And I think, yes, children are sort of stereotypically the main people who are diagnosed you're diagnosed in childhood or young adulthood, but there are a lot of young adults, especially, who are diagnosed with diabetes, and often they're really on their own to handle it. And, so in terms of or they get misdiagnosed as type 2 or as other things, because a lot of doctors don't even know that you can be diagnosed with type 1 diabetes in adulthood. So there's that issue. And then I think, young adulthood in particular is a tough time for everybody. I mean, you're struggling to find a job, you're trying to find your way, you're struggling to find your way in society and, have a partner and all of those different things. And for people with type 1, diabetes is very expensive. It's expensive to treat. And, you're just trying to become a human in society. And now you have something that you have to think about 24 hours a day. And on top of that, there's a lot of stigma and discrimination. We have people in countries where we work who, report that they're, young adults in their 20s. When their employer finds out that they have type 1 diabetes, actually they get fired, because they see them as maybe weak, or, there's a lot of stigma around diabetes. So then what do you do? Or there's also people who struggle with being seen as damaged goods, so aren't, being able to be married, or, in households where they're relying on marriage to help support their families. It's not an option for these people. So there's a lot of additional issues with young adults in type 1 diabetes. And, for the programs, they are doing the best they can. And I understand the need for an age limit, but I think there needs to be more support in thinking, maybe working with the government in thinking about how, if you are going from a program where you're 25 And at that moment, you're getting insulin pens, blood glucose monitoring, a pretty good doctor. You have all of this, then the next day it's gone. And, if you're in a country where you don't get insulin for free, you're scrambling to figure out, maybe even a completely different insulin without any education and care. And often the adult doctors often work a lot with people with type 2 diabetes, so don't even know the intricacies of care. I think, it provides really additional challenges. And so, obviously, I know there are limits to these initiatives, but I think there needs to be some real thinking about type 1 diabetes across a life course because, as we know, most people are adults who are living with type 1 diabetes. And we want to also see them live to, their 70s or beyond.
Exactly. No. I'm glad you bring this up. And I think we're going to go on to discussing sort of sustainability and long-term care within the programs, but also beyond.
Yeah.
But something that I wanted to bring up, and I think it's interesting that you've mentioned, the what happens with someone who's receiving perhaps a package of care, right, that includes certain products, and then all of a sudden you don't have this in place. And I think something that the research also showed and that we looked into was the types of products that are being supplied through some of the programs to children and young people in many of the countries that are covered. And I think something that we saw was that, traditionally many of the programs were supplying human insulins. Now we have seen, I would say, a gradual shift to some of the programs also supplying analogs, which we know for children and young people particularly could be preferred because of, lifestyle choices and also sort of the stigma that might be associated in many cases where, human insulin in a vial and a syringe, right? We know that there are various challenges for children and young people in that regard. This is a challenge that we also see across the board where we know that many insulin types that could be available to people are not quite there because mostly issues of availability and affordability. I wanted to get your thoughts on this and sort of how do you see this trend towards sort of analog use?
As a person who works in public health and also as a person with diabetes, it can be a frustrating place to be because I see both sides of some of the arguments around, traditionally human insulins are less expensive on the market currently. And so, in communities where there is access to nothing, what, a lot of advocates and the public health advocates are trying to say is let's just get some, low cost insulins in now so that people have access and people can survive. And, often doctors maybe are trained sort of in the way of using human insulins, which is slightly different from analogs. So they're saying, let's just work with what we can do to have these people survive. But, as a person with diabetes, I know the differences in different insulins, the way they work differently in the body. And I think, most people with type 1 would prefer to use an analog regime where it's either you're using a long-acting once or twice a day and then short-acting for your meals because often there's less of a risk of hypoglycemia. But what frustrates me, I think, is, we did a study, this is quite a while ago now, about the cost of production. All of these insulins cost the same amount to produce. There's a very, limited price differential between the cost of production. However, analog insulins are 7 to 9 times as expensive. And you see some of the prices going down a little bit for glargines, but not really. And, industry often says that these are the modern insulins and the newer insulins. But in fact, analogs have been around for over 20 years. So they're not modern or new. Actually, we need to negotiate and ensure that these prices are the same as human insulins because I don't see any difference in the cost of production. And obviously, people prefer to have analog insulins. And I think that's, if we want to listen to the voices of people using these insulins, this has been said time and time again. I sometimes feel like people pray into the hands of calling these new and modern insulins, sort of superior, because then in a way you're justifying this high cost. And I don't think that's fair. And I think, the only people who suffer from that is the people living with diabetes themselves.
Yeah, exactly. And I think at the end of the day, sort of the discussion that we're having is about choice,
Yeah.
right? It's about the ability to be able to choose
Yeah.
from whatever you think is going to be working best for you as a person living with diabetes, and just having that affordability in place.
Yeah.
And I think that's already a call strong to action to industry that we have also put forward in terms of looking at affordability of the whole suite of products that could be available to people, right? But I wanted to turn the focus a bit on some of the points that we were raising earlier around some of the children and young people focused programs that are being championed or supported by industry. In that sense, this as you would probably know, some of these programs are also heavily reliant on the work of partners on the ground to deliver them and actually bring products closer to people, and also education and all of the pieces of this continuum of care. But something that I think we have seen from our research is that most of the 11 initiatives that we tracked are in some way reliant on donations. And this may be support from companies in terms of donations of insulins and products. It could be financial support. How do you think this creates, do you think that this creates a fragile ecosystem? And do you think that there are steps that can be taken to improve the sustainability and long-term approaches of some of these programs?
Yeah. I mean, I think, the programs, it's great to see that they're helping the amount of people that they are. But at the end of the day, we're beholden to their decisions and, the market in a way. And I think in the last year, we've seen some impact of that, where, with the rise of the GLP-1s and some of the newer type 2 diabetes medicines, you've seen they've, like Novo, for example, has stopped making human insulin in pens, which, immediately impacted the people who are using human insulin in pens. So you can see actually how quickly a decision can be made that can actually impact a ton of people in a country. And I think, I'm not trying to over dramatize it, but I think just rely on companies to do this, you really see how fragile actually it can be. And ultimately, what we would hope is that governments would agree to take this on if they would have national diabetes programs, and they could start to incorporate some of this work within their health plans, so that, if a company decides to pull out, actually they've got the structure there to support the people in their country living with diabetes.
Yeah. And I think that's a core concern. I think at the end of the day, what we need to be talking about is, insulin is essential, it's life-saving. Without insulin, people will not survive, right? So I think it's not, and that really underscores the fact that we need to think about, what does it mean to actually not have this support in place for some of these people, or countries not being able to take this on if, the donation program suddenly stops, or if it were to stop, right? In that sense, I think one example that we have seen, and I think the ACCISS study has also tracked it and analyzed it, is the case of Tanzania, which I think to many people will serve as a bit, not necessarily a blueprint, but a good example of a country that has been in that transition into, phasing out donation-based programs and incorporating this into their national healthcare system. I know, again, that this has been analyzed by the study. So I was hoping you could share a bit about, what are some of the success factors, what actually is needed to make it work, both on the side of governments, but also the companies that have been up until then supporting some of these programs.
Tanzania, a few years ago, decided to start trying to create a national diabetes program, and then also have UHC, so that they could really incorporate diabetes care and coverage within their government system. But they are also a recipient of donations both from CDIC and from Life for a Child. And the insulin donations will continue, at least for now, but it will be it will be distributed through their supply system. So, but what we've found in this is, it is difficult. I think, so having some sustainability and creating a diabetes program, it's been really interesting to watch, but it's very difficult. And I think it takes a lot of very strong leadership, even from the NGO Diabetes Association side. You need people who are strong enough to keep pushing and to keep that relationship with the ministry open and available. And, you do also need somebody at the ministry who's interested in diabetes. And I think they've been lucky. They've had the support of the government to push these initiatives forward. And, you know, I think you need to be able to have multi-stakeholder conversations and continue those because, you know, obviously it's not just for industry to say, okay, well, you've got a diabetes program now, so we're leaving, because obviously you need to make sure that this continues for a long period of time. And we did do, I mean, this is a few years back now, but we did sort of 10 recommendations for what's needed to sort of transition away from a donation program to a national diabetes program. And I think, it's really, you know, making sure that you stay sort of on top of all of the players that are involved, and making sure you can show that you can create a sustainable program within that. But I think also strong leadership is a really important element, and I think, you know, that's what we need. I think in general for diabetes is just people willing to take on the hard work to making sure that it's not just, you know, one way or another way in terms of improving diabetes care.
To that, you also need to have, I think, of course, leadership on the government side, also active participation in dialogue with the companies that are taking part on some of the donations or supporting the countries. And from the research also, we have seen that in the case of changing diabetes in children, it is a program that is taking more of a phased approach now in some countries. And I think that speaks to the fact that, you know, it is not an immediate step. It has to be done in a way where, as countries progress with their plans to integrate diabetes care into national health systems, as reimbursement comes in place, that is when that phased approach comes into place.
Totally.
And that's the way that the company is looking at this, looking at some specific countries that may be slightly more prepared, starting with those while phasing out donations slowly or continuing donations in some of the other ones.
But I would just say that, you know, if you're going to be phasing this out, I mean, the other thing is you need to have some assurances that they're going to have access to low cost insulin.
Yeah, and that's exactly, I'm really glad that you brought this up, because I think obviously with this work that we have done, we have looked specifically at children and young people programs, right? There are some other initiatives that many of the companies are implementing across low and middle income countries to improve affordability. And we need to continue to ensure that those stay in place, and that actually the countries that are procuring some of these insulins can take advantage of some of the commitments that are in place, right? So it is a dual thing. It's not only about having sort of donations and continuing some of the programs, but also ensuring that, you know, whatever you're offering and supplying is actually affordable, which is sadly not the case, right? And you've said it with analogs, but also we know that there are huge barriers with human insulin, right? In many of the countries, even though it is classed as, you know, perhaps the lower cost, more affordable option, but many people do not even have access.
Or it's just not available. I mean, that's another issue. The supply issues are huge, actually, and for people, to be able to access something, you know, and not have to travel to 3 to 4 pharmacies to get the insulin they need, and, you know, take a half day off work. It needs to be in sort of their local pharmacy so they can pick it up. But I think also that brings up the point of it's not just insulin. I mean, you have to also have a delivery device. Either if you're in a pen, you also need a needle. You need a syringe if you're using a vial. You need access to your blood glucose meter and your test strips, or, you know, whatever you might use. Yeah, we found in our study last year looking at self-glucose testing devices in low and middle income countries, people were really having to pay, you know, the larger amount that people were paying was in the testing devices and test strips primarily. And for example, in Kyrgyzstan, insulin is provided for free. So, you know, anyone technically should be able to just go to their pharmacy and access the insulin they need. But test strips at the time were not covered. So people like, for example, a lowest unskilled government worker might have to, you know, pay up to 13 days' wages just to get their test strips that they need for the month, which we calculated that as 150 test strips. So that would be the amount that somebody with type 1 diabetes would need to test at least 3 times a day. So you can see that the issue of course, insulin needs to be lower cost, the lowest cost, the better, because that supports the treatment that you need. But all of those other elements also have to be, at an affordable cost, so that, diabetes isn't the most all-consuming cost of a household per month.
Yeah, and I think that goes to the point around the continuum of care, right? And I think perhaps too often we focus on insulin, rightfully so, being sort of, critical for survival. But also, as you rightly point out, there are very important, significant challenges in accessing. Sometimes people will be able to access the glucose monitor, but not necessarily the strips, right?
Mm-hmm.
Or similarly, we know that syringes might be in short supply in some countries. So I think the question that I wanted to bring to you more is, what is the role of those kinds of companies, device manufacturing companies, in actually supporting the situation? And do you feel that there is enough of a cohesion in terms of both on the side of, do we have enough partnerships that are aiming to bring the whole continuum of care and the whole package of products to a person living with diabetes? And do you think there's something else that perhaps governments should be doing in terms of reimbursement, integration into their own national plans, or even the procurement processes that they put in place?
Yeah, I mean, there's a lot that needs to be done. I mean, I think in the glucose testing device market, I mean, for glucose meters and test strips, I mean, we've found there's over 100 companies in the game. And I think it depends, some aren't great quality. And I think there are a lot of regulatory issues in looking at test strips. But what surprised me was when we did the research on that is actually there are sort of 4 companies that dominate the market, just very similar to insulin. And for CGMs, it's the same. It's about 3 companies that also dominate this market. So you see again, sort of, certain companies sort of taking over, but in the testing market or testing companies, I don't see them at meetings. I don't see them, in that sort of global space of wanting to take action. I haven't seen them to this point. I mean, maybe I'm missing something, but they're not there, and they haven't been pushed in a way to actually take some responsibility and look at pricing and looking at ways to better improve their devices for people, particularly in low and middle income countries. So yeah, I think they're quite behind in from what the insulin companies are doing now. I think, governments, the WHO targets on, especially for type 1 diabetes, do include 100% access by 2030 to insulin and testing devices. So technically, by 2030, all governments should be making sure that all people with type 1 diabetes have access to that whole diabetes care package. But test strips are quite far behind, and we see a lot of countries that don't even procure test strips for people with diabetes. So there needs to be a lot of awareness there, and people need to understand what the value is of testing. And, the other element of testing also has to come along with education. The doctors need to be able to, really encourage people to do tests and to see the value of it and see the value of sort of how it can help empower you in your care to really make some decisions on your own with your insulin.
You alluded to this sort of in an earlier point that you were making around sort of how the insulin market, and I would say the diabetes care market for that matter, is changing so rapidly. We are seeing these newer GLP-1s for type 2 diabetes and weight loss. We're also seeing some of the companies, as you pointed out, stopping production of pens, right? And this has caused, of course, issues for people that have to switch without perhaps a lot of warning. Maybe this is more of a forward-looking question, but how do you think this is going to be shaping sort of discussions around access to diabetes care and some of the essentials that people still need?
Yeah. I mean, I think it depends. For type 1 diabetes, I really feel uncertain. I don't really, it feels like suddenly a time where I don't really know exactly what's going to pan out. I mean, I think it's a little bit scary because I think, the hope would be that maybe with the changes to the market, then, the diabetes companies will just put down the prices of analog insulins and then, support some of the education and capacity building so that everyone can, have this choice of what they want to, how they want to use their insulin. But I don't know. I'm not sure, to be honest. We just don't know at the moment. I mean, and I think, for type 2 diabetes, I know this is not this, but I think, to me, it feels like it could be a hopeful time. I think some of the advances in the medicines, if there is a way to make them affordable, I think could help change people's lives with type 2 diabetes, hopefully. But again, it's a very strange time. In doing this now for over 10 years, this is the most sort of uncertain I've sort of felt about what's going to go into the future in terms of, care for people with type 1 diabetes.
Yeah, because breaking into a new market, I guess, speaking to the points around, brand loyalty, the fact that people perhaps maybe, and even clinicians as well, like they may not want to switch someone who is already receiving quite an effective treatment. But also, the regulatory challenges, the fact that, the perception, even though many of these biosimilar manufacturers will be able to supply and produce at quality assured standards, right? I think that's a tough nut to crack, and something that actually requires a lot of, education, awareness, and I think that has been perhaps a bit of the common thread through this conversation, that, it's not enough to establish a program that supplies insulin delivery devices, glucose monitoring. Education, awareness has to be a core component and very essential in these efforts, right? Accompanied, of course, by, the affordability and some of the other elements that need to be in place. And I was curious to hear from you, sort of, as a person living with diabetes, how do you think, and also having worked on advocacy and research for such a long time, right? How do you think these experiences have shaped your way of approaching the issue? And how do you see the role of education in this?
I mean, because I think education and sort of public awareness and empowerment, these issues are so important in type 1 diabetes. If you don't feel like you have agency or you're empowered in type 1 diabetes, you will struggle a lot more. And so, finding ways to really, to see the value, I guess it's sometimes looked at as things that can be afterthoughts. But for me, I always try and push for the idea of seeing the value of empowerment, education, and, sort of, I say public awareness because I mean looking at things like stigma, seeing those as also important critical elements in access to insulin, I think are important, because these soft values, in a way, when you are living with type 1 diabetes, are just as important to make sure you make good choices every day.
Yeah, and the issue of stigma, and I think when just coming back to the point around children and young people, I think that's a critical point where we have heard and we have seen that children at schools may face stigma. They may struggle with just handling and managing the condition. They may not have adequate access to support, and that's where sort of peer networks come in. But also, I think something that is critically important is that whatever program is being designed for people living with diabetes is with them, right? Not for them, not something that just comes from the top down. It's something that meaningfully involves the views and preferences of the people who ultimately are living with the condition and will be accessing the treatments. And in that sense, I think we've talked a lot about sort of the roles of companies and how companies can help the situation. Also governments, there's not, in my opinion, one party that can solve this on its own. It requires a multi-stakeholder approach. And the ACCISS study has been quite deliberate in putting forward recommendations of things that we need to see in terms of access to insulin, increase access to care in low and middle income countries. And I think you've outlined sort of changes that are necessary to procurement, affordability, the use of biosimilars, also recommendations around universal health coverage packages and just integrating insulin and other essential commodities. what do you see, and what would be perhaps the strongest call to action that you can make today for companies and other players in the space?
In terms of where we are right now, and really to move forward, it will take all the different players. It will take, the companies. It's going to take government support. It's going to take diabetes associations and people living with diabetes. It's going to take, healthcare providers. It's going to take sort of all of these different groups. And what I would like to see in terms of how we move forward, and if we are talking about the idea of partnerships and moving forward, is, I know it's a bad word in sort of the industry talk, but it's a commitment to transparency. And I don't mean just with prices and, practices. I mean so that every partner is equal in this sort of partnership, so that there's actually transparency on what everybody's goals are and how everybody actually, what everybody wants to get out of the situation. Because, we should all be working towards a goal of sustainable diabetes care for all people who need it. That should be the goal. But I think at the moment, it's hard to know. Sometimes the intentions of all the different groups are at different places. So what I would like to see is a way to sort of level the playing field in a way and make sure that we're all working towards the same goal. And because I think without that, I mean, it's there's a ton of recommendations that can be made, but without sort of, an agreement in terms of what we need to do to get to those recommendations or to get to, those goals, we'll just be sort of spinning in circles on the ultimate goal, which is just to improve diabetes care for people in LMICs.
I want to thank you, Molly, for being here today, for sharing your insights, also for the work that you do as part of the ACCISS study, and also advocating for better access to insulin to care for people living in low and middle income countries. And also for sort of laying out some of the, policy interventions, but also at the same time, I think a lot of the work that needs to happen also comes with that shared commitment, and everyone, as you say, being an equal partner in solving some of the issues that we are seeing still, and it seems quite frustrating, honestly, knowing that insulin has been around for such a long time, and still in 2025, we're seeing such deep, entrenched issues in diabetes care. I think something that is clear is that we have seen some positive strides, and I don't want to diminish the work that has been done by countries, by companies, and sort of the different partners that are part of the ecosystem. But I think something that is loud and clear from the work that you have done, from the research that the foundation has been, analyzing in the last few years, is that we urgently need to move away from short-term solutions. And I think the time... The urgency could not be greater in the sense that, we are seeing diabetes increasing. We are seeing more need. We are seeing still this double standard of care between people living in high income countries versus those who are not fortunate enough in low and middle income countries. It will take different partners to be part of the solution, equal partners, as you say. In that sense, pharmaceutical companies will continue, and they will need to continue to play an important role in ensuring not only that they continue to supply these highly needed products in low and middle income countries, in a context where we do see that there are many other competing priorities, but also that they ensure long-term affordability, and affordability that is not only, a blanket approach, actually looking at the different countries and what they need in order to be able to make the products, available.
I mean, that's a good point. I mean, I think that's actually the most important point in a way of I always say access to insulin is just as complicated as explaining living with diabetes, because it's not a one size fits all. Every country has its own unique issues. And, where one country might be really great at, negotiating really low prices for insulin, they might not know anything about test strips or whatever. And each country needs to be looked at and on a case-by-case basis, and really have an intimate understanding of what are the needs there, in the hope that when you identify those real, specific needs, you can help to push for sustainability, which I think is, ultimately the goal.
Well, thank you so much, Molly. Thank you so much for being part of the conversation. And if you're listening today, we hope that the discussion today maybe sparked some new ideas and also a renewed sense of urgency, perhaps, on the importance of tackling this problem. We look forward to seeing you in further editions of In Conversation.